thank you for tuning in to the summer 2024 edition of the ASPN newsletter segment, What's New in Nerve? I'm Holly Power, a plastic surgeon at the University of Alberta in Edmonton, Alberta, Canada. And today I am thrilled to be interviewing a pioneer in nerve surgery, Dr. Lee Dellon. Dr. Dellon is one of our founding members of the ASPN. He served as its second president and is a recently retired professor of plastic surgery and neurosurgery at Johns Hopkins and founded the Dellon Institutes for Peripheral Nerve Surgery. Thank you so much, Dr. Dellon, for agreeing to do this segment with us.
You are welcome. My little granddaughter, Livy, has just walked into the room. Livy, can you shut the door on the way out, please? And we won't be very long. Go on out. And you can come back in later.
That's so cute. I might have a cameo as well, so don't worry.
That's great.
So today we're going to discuss your article, the economic cost-benefit analysis of nerve implanted into muscle versus targeted muscle reinnervation versus regenerative peripheral nerve interfaces for the treatment of painful neuroma. You had first author Zachary Zamore, and this was published in the Journal of Reconstructive Microsurgery online in March 2024. Do you want to give us maybe like Cole's notes or a summary of the main findings in the paper?
Sure. When I finished hand surgery training and plastic surgery in 1978, the remaining unsolved problem, it seemed, in peripheral nerve surgery related to pain was what to do with a painful neuroma over the dorsal radial aspect of your hand. And when I trained, the correct answer, according to Dr. Littler in New York City, was to not touch the mature end bulb neuroma, just move it to a quiet place. And when Susan McKinnon was our hand fellow in 1982 to 83, we worked on this problem. What we had to do first was prove that the neuroma was the pain signaling source. And we developed a model in baboons and in monkeys. And Jim Campbell, who'd been co-chief resident in neurosurgery when I was in plastic surgery, had a 3-phase NIH grant, first to develop a neuroma, but then to do single unit nerve fiber recordings from in primates. It had been done by Marshall DeVore in Israel a long time ago in little animals, I think rats, that showed that there were spontaneous pain signals from a neuroma. So I told Jim Campbell that he could get rid of phase 1 from his NIH grant because Susan and I had already made neuromas. And we brought one of our animals for him to record with his electrophysiologic people. He was a neurophysiologist. And we left and we came back and they were ecstatic. It was the first demonstration that the end bulb neuroma was really generating pain signals, which meant we had to resect that. And then that left the question what to do with the proximal end of a nerve. And I had been putting nerve endings into muscle, the proximal ends of a painful nerve after resecting the neuroma. So we developed that as a model. And our concept was that a normal innervated muscle, when you put a nerve into it, the nerve would sprout and try to find some place to grow, but it wouldn't have any nerve growth factor in it. A cutaneous nerve, when you resect it and put it proximally, which was what was being done by most people, it would see nerve growth factor generated from the distal degenerating nerve, and it would stimulate it to grow in that direction, and it would grow into scar tissue and form a neuroma. So we had the idea, if we put the nerve in a quiet place like a muscle, an innervated muscle, the nerve would grow and possibly not form a painful neuroma. So we had that. We didn't have a behavioral model in monkeys, but we did do it in subhuman primates. And histologically, the nerve grew and regenerated, but didn't form a neuroma. There were just little sprouts going everywhere, and that was pretty much the end of it. So starting with that in 1983, we began implanting nerves in muscle, and we resected them pretty much in any given area, anywhere in the body where there was an appropriate quiet muscle approximately. And our results were that in general, 80% of the people were better, and they didn't have recurrent pain. We didn't have to reoperate on them, and we were very happy with that. And that's what we taught. And it has had several different names: transposing the nerve into muscle, or implanting the nerve into muscle. And then, as many things in life, this gets down to money. And CPT codes had a code to resect the nerve, and there was a code to implant the nerve somewhere. Previously, nerves had been put in bone.
Mhm.
Susan once put them into a vein and had the nerve grow off into nowhere special. Uh, Um, but we were pretty happy with this. And usually we could find the nerve proximally that didn't have much excursion, that it was safe to put a muscle into. When we first worked, the nerve closest dorsal radially were the thumb outcropping muscles. On the first 3 patients, we put the nerve in those muscles. And if you moved your thumb, it didn't hurt to touch the area anymore. But if the person moved their thumb, they had pain. And we knew we had to put it more proximally and into a muscle that had a low excursion. And we were really happy with that. There was no impetus to find something better. It was 2 procedure codes for an insurance company: remove the neuroma and implant it into muscle. And it takes 15 seconds, 30 seconds,
Yeah.
maybe, if you really, you're going to carefully put it into the muscle. But it wasn't stitched. It was a pretty simple approach. So things zoomed along. And then, mainly because of the concept of trying to create a way to innovate a prosthesis, Paul Soderna and Greg Dumanian came up with sort of different concepts. And these were working very nicely. And what they found is that in upper extremity, say, that was amputated here, when they put the nerve into different muscles, they could generate signals, which was their concept of amplifying the signal somehow. But
Mhm.
patients didn't complain really of pain. So I guess it was natural to morph that into the concept that we should use implanting nerve and muscle, either with a regenerative peripheral nerve interface, the way Paul Soderna does, or targeted muscle reinnervation, the way Greg Dumanian does. But these people had a lot of confounding things. They didn't just have the nerve put in muscle. They went through a lot of rehabilitation. Their brain was organized and thinking about motor function and movement. They had a lot of, if you will, post-operative therapy. Nevertheless, it made sense to try that in people having painful neuromas. And of course, that's what they did, as you all know, historically. For me, the problem was that I'm not opposed to trying new things in surgery. That's great. It's maybe an important technological advantage. But to make a difference, something should make a difference. And these operations take on time. You need a muscle graft, and then implanting the nerve and wrapping it. And then still at the end with an RPNI, it's placed deeply away from stimulation into a usually quiet place.
Mhm.
And with TMR, it's even much more difficult. You need a nerve stimulator. You have to denervate some part of an already active muscle, and then do a nerve repair or a nerve transfer, however you want to code it, with or without using a microscope. And it may take you an extra 30 minutes, depending on your facility with anatomy, to do a TMR, and maybe 15 or 20 minutes to do an RPNI. And again, the nerve ultimately is somewhere deeply implanted away from touch and traction. And their success rate with those techniques is about 80% in large series of whatever they're doing with them. And that's the same success we got implanting a nerve in muscle, but the cost of doing those is quite a lot when you add the additional procedure codes to them. So it's just like a no-brainer kind of thing. If it's just one nerve going in somewhere, maybe an extra half hour in the OR is not a big deal. But if you're
Yeah.
going to apply this prophylactically or preventively at the same time as a BK amputation, and you're going to have 4 or 5 separate nerves, you're talking about adding an hour and a half or 2 hours to an operative procedure. And then if you add that OR time to the different costs of the codes and the cost for a nerve stimulator, you're really coming up with a very much more costly approach to doing something that could be solved by a simpler technique. So as doctors, we're first supposed to do no harm, which means if there's something we can do and get the same good result for less money, thinking about money as an economy, and something costing more money is being harm perhaps to society, if not to the human being, Um, I decided to work on this with our younger people in the lab who could do the statistical analysis and so on. And that was the generation and origin, a long way to tell you, of that paper that you wanted to discuss.
Yeah, thanks for a great summary and sort of walk through some of the historic developments in our field. I will have those seminal articles from the 1980s that you wrote along with Dr. McKinnon linked for our viewers, because I think that they should be mandatory reading for anyone who's interested in peripheral nerve surgery, particularly our learners. And like you kind of alluded to, you see many techniques come in and out of favor in our field. And recently there's been this sort of focus on active or physiologic techniques like TMR and RPNI versus the passive non-physiologic techniques like transposition. And usually with the scientific method, we kind of work in the lab first and establish the scientific basis of a technique before we translate it clinically. But I think many people who do these surgeries and who are aware of the literature in this field realize that maybe the science is not as developed as it could be. Do you have any comment on that? Like, do you think we have the science to support the widespread adoption of these newer techniques?
Okay, the simple answer is no. But in other words,
Leading question, sorry.
if you were to ask the scientific information in the basic science lab, there's lots of really good work on using the nerve in muscle in some way to amplify signals to control a prosthesis. There's lots of that work. But if you actually try to look at the people who are doing this and ask them when they hook, say in TMR, you take a great big nerve and sew it to a little tiny 1 or 2 or 3 millimeter nerve innervating a muscle somewhere, that definitely forms a neuroma. And they haven't really taken a piece of their own tissue to look at, but it forms a neuroma. In Sami Tufaha's lab now, where we actually have shown that there are neuromas there. And then the concept is, well, we want to give the nerve a target. So what is the target in muscle? And years ago, Harry Bunke took free muscle flaps to the bottom of the foot and would put skin grafts over them. And he would hook up, let's say, the sural nerve, a quote, purely sensory nerve, to say the motor nerve to the latissimus, and say that the patient got back sensation in the bottom of the foot. And this was like very controversial. And I thought about it a long time, and I realized the nerve in a denervated muscle, there could be true targets like the motor spindles or the Golgi tendon organs.
Yeah.
I wrote a paper about that in an editorial called Muscle Sense or Nonsense. And there still had been, and still isn't, a published paper that shows a reinnervated muscle spindle. Now, not to give anything away, but that is being shown now in Sami's lab with histochemical staining. So we can say that a target has been identified and found, that a mixed nerve, say going into a motor nerve, can find a sensory target in a denervated piece of muscle. What about in an innervated piece, of muscle? So it isn't clear that it really needs to have a target, meaning some denervated sensory end organ to grow into. And that's really what Greg and Paul are saying. Well, we're giving it a target. We're giving it some place to grow. Well, we gave it a target. We gave it an innervated muscle as a target. It just didn't have any denervated end organs within it. And the true answer to your question is there still has not been a side-by-side study of, I'm going to qualify this in a minute in case you throw this one reference at me. There still hasn't been an appropriate study done with where the patients are randomized to getting a nerve stuck in a muscle or either TMR or RPNI. There hasn't been a TMR versus RPNI prospective study. There's Greg Demanian, and I love Greg. This isn't a thing about Greg. Greg has one study, which he calls a prospective randomized study. His control group, meaning putting a nerve in muscle, has the poorest results ever reported for putting a nerve in muscle. And I have no idea why that is, but his control group, in his study, then the TMR did come out and give better clinical results, but the success of his nerve and muscle is worse than virtually any published paper. There is a great review of that. It's got about 54 papers in it that Susan's group with Amy Moore and somebody named Louis Poplar did. And in their tree plot, except for one paper that's way out far to the left, in which the people did radial sensory neuromas, but didn't include working on the lateral antebrachial cutaneous. So you expect they're going to have a bunch of failures. Maybe half their patients should fail because they've left previously injured nerve in the territory. And that, if you eliminate that paper from that study, there's really great results. And Greg's control group is nowhere near the published results of sticking a nerve in muscle. So even though it was a randomized prospective study, something about the way they put their nerve in muscle simply doesn't match with the way everybody else had ever done it.
Yeah, those are all good points. I think pain is just, it's such a challenging thing to study, and obviously something you've dedicated your career to, because it's so heterogeneous, right? And then going back to the science question, like it's very difficult to study pain in animals as well. I mean, we have different techniques and outcome measures, but a rat can't tell you when it's in pain, right? You have to measure their behaviors and infer from that. So
I'll just say yes to your answer to that. There's a group, when I began to work with diabetes, and I did experimental studies in mice, and I'm sorry, in rats. Other basic science groups around the world repeated that. Actually, 4 other groups in Turkey, China, Maria Simonow's group did it in Cleveland, but they used a motor. But a study using pain, which is just what you said, was done in Romania in Timișoara, and they have a very poorly funded, if underfunded, or possibly not funded laboratory in Romania. And what they could do is they had a hot plate, and they just did time for withdrawal of touching the rat's hind limb to the plate. And they developed diabetic animals and showed they had longer and longer times before they pulled their foot away. Then they would decompress the nerve, and they went back to normal times. So there are models for pain that you can use in animals. A model where you use the Sims-Weinstein filaments to touch an area where the nerve has been injured. But it is a very difficult model to work with on pain, because when that's the, so I agree with you, it's difficult model, but what did you want to ask next?
So going back to the paper at hand that we're discussing, so you showed that when you're doing TMR for more than 4 or more neuromas, that would surpass the willingness to pay threshold of $50,000 per quality adjusted life year. So in a lot of cases, especially if you take, for example, a below knee amputation, many people are doing, 4 or more nerves to treat this problem. So do you think that we should be doing this procedure? You kind of already alluded to your answer, but are there, if you do you think, like, are there specific patients that you would think that might qualify for this? Number of nerves, single nerve, risk factors, that kind of thing?
I believe at the time you do an amputation, you should do something with the live ends of the nerve. And being in private practice, I haven't had many elective amputations to have to do with the lower extremity. I did have one patient who had very bad CRPS problem after multiple injuries to her leg and multiple previous operations, including many that I had done. And after 5 or 6 or 7 years, and she was a relatively younger lady with car accidents and a tumor in bone, etc. She was she had a partially denervated foot. She was developing an ulceration. She couldn't keep up with her children and her dogs. And I did send her to see, go to a clinic, see people who had amputations. And so she did agree to have an elective below knee amputation, which I did in private practice with our chief resident in plastic surgery, and my partner in Baltimore. And we identified every nerve and did the amputation, removed the bone, etc. And then I have a picture, and it's published, of all these different nerves sticking out from the muscles. And then in what must have taken maybe 10 minutes, we just took each nerve and stuck it back into the muscles and closed up the flap. And this is published 2 years ago. It's a 5-year follow-up
Mhm.
of her. And she wears her prosthesis. She dances, works out on the treadmill. And so I published that. And I believe that anytime you do an elective amputation, you should do something with the proximal ends of all the nerve, but I don't think it should require 2 more hours in the operating room. I mean, operating up in their thigh to find a place to put branches of the tibial nerve into adjacent biceps, muscles. It's right there. And then perhaps if somebody fails that, they could go on to have something else done that takes you a lot more time and costs a lot more money. You're turning a 1.5-hour operation into a 3 or 4 hour operation, and a technically very difficult operation for possibly the same success.
Mhm. Yeah, I'll link the paper that you're referencing for our viewers as well. And also there was a study that Dr. Amy Moore's group published this year that suggested that the outcomes were better when the nerves were treated preemptively at the time of amputation than secondarily. And you had that comment in PRS with Dr. Osmond, so I'll link that as well. I think it's a kind of an interesting dilemma in our field, because we know that a minority of patients develop symptomatic neuromas after amputation, but when they do develop them and we're trying to treat a neuroma secondarily, often we're getting incomplete relief of their pain. So I think that's why many want to do something up front to try and prevent it. But what we really don't seem to know the answer to is who is going to benefit. And that's work that Grant Kleiber and Kyle Eberlin and others have started to publish, looking at risk factors for developing the symptomatic neuromas and trying to figure out who we should maybe apply these techniques to.
But it couldn't be more simple clinically to take a place that has any university has a significant number of amputations, whether they're for
Mhm.
vascular reasons or diabetics with ulcers or tumors, and just randomize them into just putting a nerve and muscle or doing a TMR, RPNI, or whichever. And based on all the published literature, I would guess the results are going to be the same. There'll be some failures in each group. And then you can go back and see, did you miss a nerve? Did the nerve pull out of the muscle? Is the muscle sitting next to where the prosthesis is resting? And so my patient that we did the elective work on has no phantom limb pain either. And I just would like to say this, since it's going to be, people might actually watch this. Do you have a concept, Holly, what phantom limb pain is due to? You think
Sorry,
anybody, why do people get phantom limb symptoms?
why do they get phantom sensations or phantom pain?
Yeah.
Well, it's mediated centrally as opposed to peripheral, like generation of pain. But I mean, I think we don't totally understand it. So,
Okay, can I tell you my simple-minded answer to this? Let's say that this is the tibial nerve, and every one of these fingers is a fascicle to a toe.
mhm.
Okay, and here's, wait a minute, I got just what I need here. And let's say this is the tibial artery. So the tibial artery is tied off, and the nerve's cut back and dropped somewhere, but somewhere the tibial nerve is next to the artery, next to the nerve, and every time the heart beats, there's a little pulse that goes into this fascicle. And so the brain is being stimulated by a fascicle to the big toe, and it's going to think something's happening to the big toe. When I operate on people with phantom pain, I just separate the nerve bundle from the artery. Yes, I move this and stick it in a muscle, but there's no longer an artery touching a given fascicle of the nerve. And I honestly think that's all that phantom pain is. Yes, everything we appreciate consciously is occurring in our cortex. But I think it's this physical relationship between the pulsating artery being next to a nerve that can give the sensation of phantom limb.
Okay,
That's
interesting.
my theory. Remains to be proven. But if you think about everything we do in these patients, we move the nerve away from the main vascular pedicle and put the nerve somewhere else, and the phantom limb stops, at least in my experience. And now I'll share one other new. This is like this week, information from this week.
Ooh.
So you may or may not remember or know that I worked for a long time with leprosy patients.
Mm-hmm.
In the time I was worked with leprosy patients, I never saw a painful neuroma in a leprosy patient.
Hmm.
So suppose that's true. So recently I've been through, you cannot find a report of a painful neuroma in a leprosy patient that's ever been published. Okay, so now we've done this study, which I'm sending in as an abstract to Aspen in case you're on the committee.
Ooh.
We've sent out questionnaires to many experts in the field of leprosy. And the first, we have responses now from people in 8 different countries with an experience with more than 30,000 leprosy patients. And 3 of the 11 respondees so far have never seen a neuroma in a leprosy patient.
Hmm.
And one has seen maybe one, and one has seen less than 5% in an amputation group, and another has seen perhaps less than 15%, not 50 or 75%. And so it's going to turn out to be true that leprosy patients who have amputations have very little amputation neuroma or phantom limb. So I've been puzzling, and this is going to get back to one of the things you asked. Why would a leprosy patient who has an amputation not develop phantom limb? And I don't know whether any of you have seen or read, but in our book on somatosensory testing and rehabilitation, we have the homunculus drawn in very easy to understand patterns. And if you take a monkey and you amputate the finger, but you don't have to amputate the finger, you just cut the nerves to say the middle to the middle finger. The brain is still there, right? But it's not getting an input from the middle finger. So what happens is, as maybe you know, the cortex that represents index and ring on either side enlarges. And then
Mm-hmm.
if you go back later and repair the nerve, it comes back, and the middle finger is again represented on the cortex of the brain. So in a leprosy patient who may go with an anesthetic limb for 5 or 10 years till it ulcerates or gets eaten off by an animal or something, the
Mm-hmm.
brain thinks it doesn't have a foot. The brain is gone for years thinking there's no foot there because it has no sensory input. And maybe when that amputation occurs, the brain has already done so much to ignore anything that happens that it still doesn't know it had really a foot amputated. Um, so we're going to need to come up with a mechanism for why painful
Yeah.
neuromas don't occur or occur only rarely in people with leprosy. And it may have to do with, and this gets down, the reason I said you asked this about doing an immediate or a delayed TMR, RPNI, or nerve and muscle. If you do it delayed, the patient's brain has already had years perhaps of really bad painful input. And
Yeah.
then it's not a matter of just stopping the nerve from firing, but you have all this association cortex related to years of sensory input with pain. And if you do it right from the beginning, the nerve is not really sending years of, the person wakes up and their hurt nerve isn't really sending any pain messages, except maybe a little bit for the first couple of weeks when they're on pain medicine.
Yeah.
Maybe something related to central processing, as you said, as it relates to people who haven't felt their foot for a long time and have an amputation compared to those who have a vascular problem and have their foot amputated. But that's, really new information just from this week.
Yeah, that's really, really interesting. Thanks for sharing that. And it kind of, I wonder if that's also why, I think it was Kyle Eberlin's group who published on risk factors. And one of the protective factors in terms of who develops symptomatic neuromas after major limb amputation was diabetics, and people with vascular disease are less likely to become symptomatic. So maybe it's kind of along those same lines. Um, I want to thank you so much for taking the time to speak with me and for our viewers today. It's such an interesting field, and there's so much work left to do. And to hear the perspectives of someone with so much experience and who has treated nerve pain his whole career is really thought provoking. And you've definitely given me some things to think about in what to research and questions to ask.
Well, anyway, I would just say for the young people going through residencies, they're going to try all these new things, and they should, and they're fun. But you just should think about the cost of introducing a new operation. And if you're going to get the same success rate for something that's going to cost the insurance carrier or somebody or society an awful lot more money, even though it may be fun to use a nerve stimulator and do these type of technical things, it may not make any difference in terms of the ultimate result for the patient.
Yeah, we need to figure out which patient group is going to benefit from the added expenditure for sure.
Thank you for such a great interview.
Thank you.